Good morning, Mr. Governor. I am here, along with Christian, Julie, and Sarah, to talk about one of the most pressing problems in our state of Wisconsin, and that is infant mortality, particularly in the African American community. Together, the four of us were asked to come up with a viable answer to the problem. What action can the state of Wisconsin take to reduce the infant mortality rate of African American infants? We would like to propose our solution momentarily. But first, let's explore some history and the political background related to our issue. Infant mortality is the death of an infant before his or her first birthday. The infant mortality rate is the number of infant deaths for every 1,000 live births. In addition to giving us key information about maternal and infant health, infant mortality rate is an important marker of the overall health of a society. In 2016, the infant mortality rate in the U.S. was 5.9 deaths per 1,000 live births. This means that nearly 6 babies died for every 1,000 live births. African American infants in the U.S. are more than twice as likely to die as white infants. 11.3 black babies compared with 4.9 white babies. A racial disparity that is actually wider than in 1850, which was 15 years before the end of slavery. Here in Wisconsin, it's even worse. African American babies die before the age of 1 at a higher rate than any other state in the U.S., at 14.28 per 1,000 live births. This rate is nearly 3 times as high as in white babies. And while our state has the greatest number of African American infant deaths in the country, we can infer that most of these are coming from Milwaukee, where almost 3/4 of the city's residents identify as Black. The leading causes of infant death include birth defects, or problems that occur while a fetus is developing in the womb, preterm birth, and low birth weight. In Milwaukee, nearly 60% of all infant deaths are due to prematurity. Sudden infant death syndrome, or SIDS, which is the unexplained sudden death of infants, maternal pregnancy complications, and unintentionally inflicted injuries such as suffocation. Infant mortality is generally associated with poverty, low maternal education, poor access to health care, and lack of adequate prenatal care. Not only do African American women tend to have less access to prenatal and postnatal care, but they also have far more trouble connecting with basic preventive health care services. That means they are also more likely to have untreated chronic medical conditions that can affect a pregnancy, such as diabetes or high blood pressure. There is also a correlation between how early on in a pregnancy a woman receives prenatal care and the baby's health outcome. Women with unplanned pregnancies tend to start prenatal care later than other pregnant women. Studies are now concluding that education and income offer little protection. An African American woman with an advanced degree is still more likely to lose her baby than a white woman with less than an 8th grade education. Because of these findings, experts are now citing racism as another factor in the high rates of infant mortality. As one author eloquently said, "For Black women in America, societal and systemic racism can create toxic physiological stress, resulting in conditions, including hypertension and preeclampsia, that lead directly to higher rates of infant and maternal death."
In both federal and state levels, there has been a history of proposed and passed legislation to help aid in the reduction of infant deaths, primarily in the African American population. Here in Wisconsin, the statute 253.16 was passed by the Wisconsin State Legislature. The purpose of this legislature was to award a grant each year to a city health department to provide a program to reduce infant mortality and morbidity. The grant will be awarded to the area with the highest risk of infant mortality. Under Statute 253.16, the legislature explained 6 ways the city health department could lower infant mortality rates. Some of these ways included collaboration with local academic institutions and hospitals to implement practices to reduce infant mortality. A second was to assess the availability of preconception, prenatal, and postnatal services. And lastly, to develop and implement models of care for women at high risk of infant death. Statute 253.16 also requires local health departments to prepare a report on infant mortality annually. H.R. 6174, or also known as the Newborn Act, was introduced by Representative Steve Cohen of Tennessee on June 21, 2018. The purpose of this proposed bill is to authorize funding for the implementation and creation of infant mortality pilot programs in areas of the United States with the highest rates of infant mortality. The funding from this bill would supply funds to 15 counties in the highest rates of infant mortality and would address the 5 highest causes of infant death, including birth defects, preterm birth and low birth weights, sudden infant death syndrome, maternal complications, and infant injuries. Another proposed bill is H.R. 4571. This federal bill was introduced on February 12, 2016 by Representative Gwen Moore of Wisconsin. This bill is also referred to as the Reducing Unexpected Deaths in Infants and Children Act of 2016. This bill amends the Public Health Service Act to improve the health of children and to better understand and raise awareness about sudden infant death. The bill would require the Centers for Disease Control, or CDC, to award grants for improving death scene investigations of sudden unexplained death in infancy and childhood, improved investigating training on infant and child deaths, increase autopsies for such deaths, and to increase the surveillance on stillborn births. This bill also requires the Department of Health and Human Services to establish a task force to develop a national research plan to determine the causes and how to prevent stillbirths. Based on my research, there will be 2 congressional committees involved in making the suggested changes. First, the Energy and Commerce Committee in the House of Representatives. This committee is responsible for matters including food and drug safety, public health and research, and environmental quality. The second committee would be the Committee on Health, Education, Labor, and Pensions in the Senate. This committee covers over 20 topics, some including public health, equal employment opportunities, and occupational safety and health. The Secretary's Advisory Committee on Infant Mortality advises the Secretary on programs by the Department of Health and Human Services directed at reducing infant mortality and improving maternal health. 2 agencies included in regulation of the proposed policy would include the Department of Health and Human One advocate for healthy births is the Life Course Initiative for Healthy Families. This was established to address the high rates of infant mortality among African Americans in the state of Wisconsin. Stress is one of the many root causes of infant deaths, as you can see based on the image on this slide. This organization's goal is to create healthier birth outcomes by reducing the disparities and the root causes of infant death, including stress. A second advocate is UNICEF. Breastfeeding is known to have many positive health effects on both infants and mothers. Breastfeeding protects against illnesses and death. Immediate skin-to-skin contact and breastfeeding significantly reduces newborn mortality. UNICEF, in collaboration with the World Health Organization, or WHO, have formed a global advocacy initiative to increase the commitment of breastfeeding to improve infant health, nutrition, and development. Political parties are also shown to affect infant mortality rates. According to a study done by the International Journal of Epidemiology at the University of Michigan, infant mortality is 3% higher under a Republican administration and 1% lower under a Democratic administration. But the important question is why? This is because Republicans are more likely to view health disparities that are related to infant mortality as inevitable, meaning they cannot prevent them from occurring. On the other hand, Democrats are likely to view the same health disparities as a problem that can be solved via government intervention. The presidential party affects the African American population more than other populations because the infant mortality rate is already so much higher in African Americans versus other populations. This graph from the International Journal of Epidemiology shows how infant mortality is broken down by specific presidents. Based on this chart, the Obama and Clinton administrations had the lowest infant mortality rates, whereas the Reagan and H.W. Bush administrations had the highest mortality rates.
Good afternoon, this is Christian Wood, and first off I'd like to thank Sarah and Christina for giving the lead-in for our policy proposal to decrease the infant mortality rate for African Americans living in Wisconsin. Our proposed policy to do that would be the expansion of the Badger Care Plus Medicaid program to include reimbursement for doula services to pregnant beneficiaries. As of August 2018, there were 18,824 pregnant women participating in Wisconsin's Badger Care program, and 4,387 of them were African American. So there's a huge opportunity here to decrease the infant mortality rate of African Americans just by focusing on Medicaid beneficiaries. What is a doula? For those that do not know, a doula is also known as a birth companion, birth coach, or post-birth supporter. Is a non-medical person who can provide emotional and physical support to women before, during, and after childbirth. How can African American women benefit from doula services? Well, research shows that doula services are associated with fewer obstetric interventions, fewer complications, less pain medication, shorter labor hours, higher APGAR scores, and a potential for reducing racial, ethnic, and socioeconomic disparities in breastfeeding initiation. The statistics behind using doulas is also quite impressive, as research affirms that mothers using doula support are less likely to give birth preterm. And as Christina spoke about earlier in the presentation, preterm birth is responsible for the majority of infant mortality. Doula care is associated with a 22% lower risk of preterm birth and a 10% decrease in preterm birth. Of the infants who survive preterm birth, Wisconsin spends $76 million in extra medical costs. These statistics show that African American women that are expecting could benefit from using a doula to decrease their likelihood of preterm birth and potentially decrease the health disparity found between white and African American infants. With the enactment of this policy, there is a potential for a 10% decrease in Medicaid enrolled African American infant mortality relating to preterm birth and a 2.4 decrease in infant mortality for all Medicaid beneficiaries. The intended consequences of this policy would be to decrease the infant mortality rate of African Americans in Wisconsin while providing expecting African American mothers with the resources they need to deliver a healthy baby. The unintended consequences are mostly positive, and there's a real potential here for the policy to not only achieve its intended goal, but to decrease the overall Medicaid spending in Wisconsin. If you look at the first table, titled Medicaid Preterm Savings with Doula Policy, you'll see that we took the number of anticipated Medicaid births as of August 2018, which was 18,824. We divided that by Wisconsin's preterm rate of 9.4% and got 1,769 preterm births. Now, research suggests that 10% of those would be preventable with doula support, which would give us 177 prevented preterm births, which is an estimated savings of $51,000 an infant, or $9,027,000. And an estimated savings per birth of $480. Another unintended consequence could be that if the policy was enacted in all 50 states, and because preterm birth is responsible for 1/3 of all infant deaths and costs the U.S. $27 billion a year, Medicaid nationwide could be greatly reduced. Research suggests that cesarean deliveries are 28% lower for doula-supported births than that of Medicaid beneficiaries without doula care nationally. If you look to the right in the table titled Medicaid Cesarean Savings with Doula Policy, you'll see again that we took the anticipated number of Medicaid births, which is 18,824. We divided that by the Wisconsin cesarean rate of 32.8%, and that gave us 6,174 cesareans. Now, it's estimated by research that 28% of those are preventable with doula support, which would give us 1,728 vaginal births at an estimated savings of $4,459 and overall $7,705,150. The estimated savings per birth would be $409. If you add both the preterm and the cesarean savings together, you would have $889, which is our proposed reimbursement for doula services. In addition to the formidable decrease in infant mortality, because doulas may also influence stress reduction, nutrition improvement, health literacy improvement, and improvement in emotional well-being, research suggests that millions of dollars could be saved by breastfeeding initiation, and doulas are astute in this area. A negative consequence lies with the current CMS guidelines to prevent doulas from working autonomously and receiving reimbursement. Problems can always arise if the vision and philosophy differ from the licensed practitioner who the doula is working under, who has been recommended by. When this policy is enacted, Wisconsin will have joined the only other two states in the U.S., Oregon and Minnesota, that have expanded Medicaid benefits that allow reimbursements for doula services. There has been documented complications with the implementation in both of these states, and it is of utmost importance to address these issues within the new policy to see that the expansion for reimbursement for doula services to decrease Wisconsin's infant mortality rate among African Americans succeeds rather than fails. Issue 1. Reimbursement and low reimbursement rate for doula services. Wisconsin should develop a system to require licensure so that doulas are paid directly rather than through a supervising provider. In both Minnesota and Oregon, this has been a source of contention because not only does this beg the question as to who the doula is working for, but also who will reimburse the doula. While the licensure is being worked out, Wisconsin could utilize CMS's final rule, CMS-2334-F, that expanded the definition of who can provide services covered by Medicaid. Previously, Medicaid required services be rendered by a physician or licensed practitioner, but the new rule grants states the option to reimburse for services recommended by a physician or other licensed provider. Minnesota and Oregon also have low average reimbursement rates, $411 per birth. This value is much too low for the services that a doula provides, and research suggests that a reimbursement rate of $889 would be cost-effective and potentially save healthcare dollars when the 10% decrease in preterm birth, 28% reduction in cesareans, and the plethora of other cost savings a doula provides are factored in. Issue 2. Expanding to rural areas with mileage reimbursement. Both Oregon and Minnesota have had issues with providing services to Medicaid recipients living in rural areas. Some doulas travel substantial distances to meet with patients, and travel time and expenditure alone will often outweigh earnings for home visits for patients. By reimbursing doulas traveling to rural areas, more women will have the opportunity to participate in a program that will yield positive results. Issue 3. Doula matching with the mother of the same race, ethnicity, and language. Research suggests that most doulas are white and that mothers seeking doulas would be more comfortable with services rendered by another person of the same ethnicity and obviously the same language. To increase the doula pool, subsidies, grants, and funding for doula certification should be directed to communities of diverse ethnicity, lower income, and rural areas. This will increase the diversity of the doula workforce and improve its capacity to meet the needs of Medicaid beneficiaries. On January 1st, 2019, Wisconsin's Badger Care Medicaid program will extend to reimburse for doula services to beneficiaries and be carried out in 3 phases. The first phase is the initiation phase. Pregnant women covered under the Badger Care program will meet with a Medicaid OBGYN to confirm pregnancy and discuss birth-related options. Medicaid providers will be educated on the benefits of a doula and be able to effectively convey the information to the expecting mother. Upon the expecting mother's first visit, the mother will be assessed in relation to statistical criteria that would put her at risk of a preterm birth. While all Medicaid beneficiaries will be offered doula services, women with a higher risk will be strongly recommended. If the mother chooses to utilize a doula throughout her pregnancy, she will be given a list of participating doulas from which she may contact and interview before choosing. The next phase is the working phase. After the mother has chosen a Medicaid-sponsored doula, the working phase will begin with a home visit and 2 second and third trimester office visits where the doula will be able to assess the progress of the pregnancy, educate the new mother about nutrition and stress reduction, as well as answer any questions that she may have. The third phase is the closure phase. This phase will begin with the labor and delivery of a full-term, healthy infant and end with a wellness home visit where the doula will be able to assess the mother's ability to care for her child. A breastfeeding assessment will also take place. As long as education, a about the additional resources available to the mother through her Badger Care Medicaid plan. At this time, the doula can submit for an $889 reimbursement. So as you can see, and as the research suggests, when enacted, this program has the potential to not only decrease the infant mortality rate among African Americans, but it has the capacity to decrease Wisconsin's Medicaid expenditure by offering a cost-effective solution for providing quality care to the people that need it the most.
In conclusion, Mr. Governor, after our in-depth research, the state of Wisconsin should extend their Badger Care Medicaid program to include a Medicaid doula extension package, which would contain reimbursements for doula services as a solution to reducing the mortality rates among African American infants. A doula is a non-medical individual who assists the woman prior to, during, and after childbirth. A doula provides emotional support and physical help as needed by the soon-to-be mother. There are several things that can be associated with infant mortality, such as poverty, low maternal education, poor healthcare access, and a lack of adequate prenatal care. By expanding the Badger Care Medicaid program and reimbursing doulas for their services, it will provide African American women the resources they need for a healthier delivery, such as education, healthcare access, and proper prenatal care. After the implementation of the Medicaid doula extension package, infant mortality among African American women in Wisconsin will decrease by 6% in just 6 months. As committee staff members in Wisconsin, we want to make a change and reduce infant mortality, and the key to solving this problem is to create a Medicaid doula extension package. Thank you for your time, Mr. Governor. We look forward to working with you in the future passing this policy here in Wisconsin.